I think that you can assume every part of your clinical care will have a touch point with AI, even as of today, but certainly within the next year. And we can also assume most non-clinical people will be leveraging AI in some capacity to look up stuff.
Okay, well, welcome to the Hat Rack. I'm Dr. Bill McCauley. I'm the Associate Dean of Continuing Professional Development and Faculty Development here at the Schulich School of Medicine and Dentistry. And on this episode, we are going to, go back to the future a little bit. We're going to talk about artificial intelligence in medicine. And I know our dedicated listeners will recall that about 2 years ago, we talked about artificial intelligence in medicine with Dr. Rob Arnfield. But 2 years is a long time in artificial intelligence. And so we thought, well, maybe it's time to revisit the subject and see what's going on. And so we have a couple of people in our studio that have got expertise in artificial intelligence. And I want to introduce first Dr. Amrit Kripalani, who is a pediatric nephrologist from London Health Sciences Centre and Children's Hospital, West Ontario. Welcome. And Dr. Frank Myslik. And Frank is a fellow emergency physician. And you'll have to get this title right. Let me get the title right, Frank. But I believe it's the Senior Medical Informatics Officer.
Informations officer, but three for four letters is not bad.
Right. Yeah. Senior Medical Information Officer at London Health Sciences Centre. And both of these guys are involved in AI and are happy to talk to us about it. So maybe, Amrit, we'll start with you. Just tell us a little bit about your involvement in artificial intelligence in medicine and what you've been doing with it in the last couple of years.
Yeah, so my main sort of academic interest is in medical education, so training medical students, residents, healthcare providers. So a lot of my work has been focused on how to thoughtfully incorporate AI into medical education, both using it to help teach learners, but also using it to help understand how learners trust and engage with AI during their medical education.
Okay. All right. And so you teach that, you do workshops, like what's your involvement?
So it's kind of doing at different levels. From a practical kind of on the ground level, it's something that I've used in teaching. So in the classroom during, with medical students, residents, using AI in teaching. So whether that's having something like a chatbot, ChatGPT, Gemini, as part of the activity with our large group sessions. We've done a couple sessions where we look to see how students may change their answer to a certain question based on a ChatGPT response. What if ChatGPT is right? What if it's wrong? And what factors influence whether students trust these AI tools?
Cool.
And then from a research perspective, looking into how we can use this to help generate personalized training plans for different students as well.
And let's just carry on with that thread a little bit. Students are all using generative AI, I assume?
Absolutely, they are.
Right. And do you think that they are trusting it more than they had in the past, or do you think that it is becoming a default for them?
I think it's definitely become one of their first go-to sources when they need that quick review, the quick notes on something. When you're walking down to the emergency department, you're going to pull something up. And I think for a lot of them, things like ChatGPT are the first thing they'll pull up. In terms of trusting it more, I think one thing we've seen is that there's a lot of different factors that influence. I don't think we can, as an umbrella term, say they trust it or they don't.
Yeah.
For instance, we've seen that with basic science or foundational content, they seem to actually trust it quite a bit.
Mm-hmm.
When it comes to clinical content, it's a bit more hit or miss. We did a case of nephrology teaching where we would give them essentially the same question, but just packaged in different ways. So we would ask them, what does it mean if you see XYZ on a urinalysis or in blood work? And it was kind of very basic science. And they would trust ChatGPT's answer. But when you package that same question into, a 15-year-old patient presents with blah, 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 you see this in the blood work,
right.
They actually trusted it less.
Why do you think that is?
I wonder, I guess the optimistic part of me would be, hey, maybe once you put a real patient and a real human element to it, there's some degree of, I don't know that I want to trust this with that decision.
Stakes are higher.
But maybe part of it just has to do with how competent they feel about their knowledge in that area. Because we've also seen that they trust it more in areas where their initial answer was wrong.
And Frank, how about you? How did you get involved in AI and what are you up to now?
So in my SMIO role, it's interesting. So I pertain for everything for digital health and medicine these days. And so my whole role is how do you kind of govern that and move the needle forward for anything in the hospital. And artificial intelligence, I think, touches that in every way right now. I would say over the last few years, it became more of a nice to, that's nice and fringe, but maybe it's just a cool fad to clearly a priority. So when we talk about things like getting people to do their charts online, accessing, results in a quick time fashion, trying to predict and help with hospital flow, I think artificial intelligence comes up in every shape, way, or form to kind of as a solution, right? And so artificial intelligence is this kind of catch-all of a lot of things, but ultimately to really use it aptly, you need good information and good data. So a lot of the foundation that we're working on right now is how do we get that data entered in a proper fashion, collated, accessible, and then actually use artificial intelligence after to improve that. And what I mean by that, it's pretty much everything you can think of. So there's the clinical decision making that Amrit was just kind of talking about there. There's probably the one that maybe a lot of people listening here think about, which is AI scribes, the ability to get information more quickly onto the system in a more unified, succinct fashion that takes less time and, more importantly, allows clinicians to have a little less admin burden, but more importantly, see more patients. But those are probably the main ones that we think about. There's all the other ones in the background, the ability to, again, predict what's coming down. So if we knew when, there was a higher disease prevalence or an inevitable bed block in the hospital, how to flow people out, predict when people can actually be discharged. There's that level. And then there's actually other levels, which are the clinical decision making. How do we actually allow people to have the best information at that time point? I think over the last 20 years, we've all gotten better at Googling, like what's the dose of this? And we use different websites to look up something. We've now hit a threshold where I think a lot of people type it into Claude, ChatGPT. There's open evidence, which is a very well-known one, and people utilize that for their information. So there's that level. And then you can even take it to the non-clinical, which is the administrative, allowing people to use Copilot to draft, emails, find scheduling. Like, honestly, scheduling and trying to find 5 doctors to find the open access time in their calendar is a nightmare. So we use admin assistants and so forth. But AI actually can help with a lot of that stuff. And again, that's kind of the admin burden that we talk about that's adjacent clinical. And then it kind of cascades from there. So it a lot of stuff.
I want to ask a basic question. You, at the very beginning of what you just talked about, you used the term digital health.
Yeah.
What do you mean by digital health?
So I would say most healthcare in the year 2026, at the time of this recording, is probably almost all healthcare is digital. So when we think about paper charts, if we compare ourselves to other countries, we are inevitably lagging behind quite a bit, at least compared to equatable countries. And so at this own hospital, we still chart at the, time of this recording, that we are doing things on paper. We're trying to get everything online. And so almost all health's digital. Think about, like, at least for my day and probably your day, you enter the hospital and you open up the electronic health record. That's literally probably the first touch you have of the day. Maybe you see a single patient first, then open it up. But we have to put everything in on the computer. Whether that you're a pro or con against, that's not really relevant because that's the reality of it. So how we see patients, where they are, what the results are, what they've said, what the nurse has put in, what the clerk has put in, what we're communicating to others, it's all done digitally right now.
And I think that's probably also true from the patient side too, right? When something is wrong, when you have a new symptom, we as healthcare providers see them in the office, but patients are probably, we know from surveys, are interacting with digital health resources before they ever come see us as well. What does it mean if I have this? What does this mean? Whether that's through Google, WebMD, and now AI chatbots as well.
Because even the search engines now, I mean, you type something into Google, you get an AI response, right?
Absolutely.
It incorporates Gemini into it. So AI is there, and people, my sense is that people will say, "Oh, I can never use ChatGPT." Well, you're using AI if you're using Google. That's
Yeah, you can turn that off, but the short answer is if you do nothing, you just use it at this day and age, that's like you get that AI summary at the top, and that's pretty prevalent in most search engines now. Yeah.
right.
And also even taking one step back, whatever resources you're finding from Google, how many of those have used generative AI in that content generation as well?
Right.
So
Right. Yep.
It's interesting that you brought up the patient perspective. One of the reasons of the timing of this podcast is that we're having a conference in June on called HEAL, which stands for Healthcare Enhanced by Artificial Intelligence and Learning. It's going to be on June 24th. And we really want to have a patient perspective at that conference. So we're going to have a patient representative on a panel talking about ethics. We're going to be interviewing patients in advance of the conference, just random people. I'm going to go to the mall and interview people and find out what they think about the
Do
use of
malls
AI.
still exist?
Yes. Yeah, I think they exist.
The malls exist. Yeah, we're going to go to
Okay.
Yeah.
This one, at the time of this recording,
Yeah, the
malls
mall
still
still
exist.
exists. Yeah.
But there's no Amazon at the mall.
Oh, okay.
Just so you know.
Yeah.
So I'm going to go and interview people and find out what they're thinking. What do you think? What do you think patients feel about the use of AI in medicine?
Yeah, that's a great question. I would say it's variable. And what I mean by that too is like you'll have some people that aren't even aware. Like nothing has changed in their day-to-day life. They haven't even thought about it. So there's that camp. There's ones that are, either progressive or started to utilize it. Again, looking up symptoms ahead of time. Even a lot of stuff in the province that are moving to like 811 and stuff, they're using and leveraging a little bit more AI in the background there. So I think they're becoming more familiar with it. And then there's another camp, obviously, that is anti-AI, right? Just from the whole concept of it, I don't think specific in healthcare. There are tools. I'm aware of a commercial product where patients now can go in and record your encounter with us as clinicians that will synthesize the outcome, what we said, and provide a more layman terms approach for them. I think still are the days.
So that's like a scribe for patients?
Correct. Yeah. Which we're into the phase where people will just open up like they're recording on their phone. And they'll record the whole thing, what we're talking about. It's now hit to a phase where they'll actually do, a patient perspective scribe that gives them like, this is what the doctor said when they said renal calculus, or struvite crystals or any of these things. They'll actually kind of I don't want to say dumb it down. It'll provide it in a context that is accessible by them. Right. And we actually do see that from a lot of the larger electronic health records, Oracle being a very big one in the world, the one that we use here in London. One of the things that we're rolling on in the future is they have a patient portal, but they're layering on the generative AI in the background to be able to provide a synthetic in summary for the patients of what that encounter actually says.
In the patient's own language.
Correct.
Right.
And yes, both like in their own language. I think they have most of the ones in the world. So it's actually, accessible by them and whoever they get access to.
I think when we think about the patient perspective on AI, I think, again, we're probably seeing different perspectives based on a lot of factors that are really prevalent in the healthcare system and a lot of the issues we've been dealing with for years. So even AI chatbots, it was already well established that people who had less access to a family doctor, less access to healthcare, were more likely to look up health information online.
Okay.
We know now from recent CMA survey that something like 1 in 5 patients, or 1 in 5 people in the general public have said they are using AI tools to look up healthcare information, and it is disproportionately people who don't have access to a healthcare provider. We even have global data showing that something like ChatGPT usage is higher in countries with fewer physicians per capita, even when you control for GDP, internet access. Mm-hmm. So I think in terms of the patient perspective, my fear is that the people who don't have access to healthcare may be the ones who are most reliant on these tools and maybe most susceptible to potential misinformation as well.
Right. So it's also, this whole discussion is a game changer for the way that physicians practice as well, in terms of the way they interact with patients and what the role of the physician might be. I mean, I think it's reasonable to say that physicians have always been the experts, the content experts, and have always sort of had control over the healthcare interaction. And now with the availability of some of these tools, that might be flipping a little bit, right? So the patients might have more, or at least as much access to the information, and physicians are going to feel a little bit like they're losing control over the situation. So how do you think physicians are going to navigate this in the future?
That's a great question. I would say some are going to stamp their feet and hate it and yell to the wind. And then I think the pragmatic approach is going to be to lean into the drift. When to use an equatable example, patient portal access is always this contentious thing that comes up. Should a patient...
So patient portal access is a patient having access to their own health record.
Correct.
Right.
And here in Ontario, through Connect My Health, which is one that you can just get from a provincial viewer, the general trend is that patients should be able to access their data in a real-time fashion when they need it so they can see it. Now, there's different perspectives on what should be accessible, and I don't want to talk about all that in detail, but when you talk to some clinicians, some are very vehemently against it. Like, they should not have access. I should be the one directing and explaining and collating stuff, because sometimes there is some misinformation. People can become hyperfixated on a very small thing that is negligible, but a patient doesn't have that perspective. On the flip side, there are some that are very pro, being able to, yeah, of course I want them to see their, blood sugars and their results and communicate. So I'd say AI is very equatable, where we're going to have to be acknowledgeable that this is something that they're going to have. And so how do we pivot as opposed to resist? At least that's my perspective.
Absolutely. And I think we need to be proactive with it. It may not be feasible to tell people, hey, I don't think you should use this. If people want to use it, they're going to use it. And I think the better approach may be to be proactive with it. So having that open discussion in clinic, in the emergency department, wherever, hey, I don't think these tools are reliable, but here's some resources. If you do choose to use these chatbots, just know that sometimes they can give misinformation. Sometimes they can overgeneralize. If you see anything that is different than what we chatted about, please don't take advice from these chatbots, but you feel free to bring it up at the next visit. I'm happy to chat about it. So kind of having that open door approach, as opposed to trying to shame people into not using it and then having that brick wall up. Because I think I'd rather know if patients are using it and have that open discussion.
And there's I was going to call it an old adage, but it's hard to say old when artificial intelligence is not that old. Well, I mean, the roots of it go back a long way.
It's old in the trajectory and acceleration of the AI,
right,
where it's going. Yeah,
it's going way up.
Yeah,
but the adage is that because a lot of physicians and other professionals were concerned that they're going to be replaced by AI, right? And so I think that the adage is that physicians aren't going to be replaced by AI, but you might be replaced by physicians who use AI.
Yep.
Right.
What's fascinating about that replacement thing? This may be shocking to everybody. There's a lot of ego in medicine. I know.
We need a whole podcast on that revelation.
We did this study. This is just looking at online perception, so kind of online forums and stuff, but in medical forums, so like medical subreddits and all that. And just to see perspectives about this whole idea of, are we going to be replaced or is it going to enhance? And there was this very clear social hierarchy where everybody felt like anybody, quote unquote, below them on a social hierarchy was replaceable.
I see.
So physicians thought that non-physician healthcare providers could be replaced, but they couldn't.
Right.
Subspecialists thought that, well, generalists could be replaced, but not me. I'm the surgeons thought non-surgeons could be replaced. Everybody thinks that they are irreplaceable because only we know our job and all of what it entails in our specialty, but we think everybody else could be replaced. So there's so much ego that goes into it as well.
So, and I mean, we're not going to be replaced, but our role is going to change.
I think our role is changing right now. So as Amrit just said, a lot of learners are already using AI. Like, you even talk to some of what I would call kind of old school physicians or even, senior physicians, they're using it in some way. They're just almost like embarrassed to talk about it because it feels like a drift from what is innately core to us as physicians. But I wouldn't even call it a crutch. It is an assistant. And going back to digital health at the beginning, we use electronic health records. We use the web to look up dosages of meds. Like, gone are the days where you're supposed to be expected to remember exactly to the T the weight-based kilogram, antibiotic dose all the time, because that has prone to error. And so we do look those up. So we already use tech that way.
Yeah, indefensible if you get it wrong.
Right? Totally.
It's right there at your fingertips. It's in the palm of your hand. The answer's in the palm of your hand.
What's the standard of care? You can look this up, right? And so I would say that we're going to change because it's going to be an assistant. We're all burdened in the same way. Volumes are going up, complexity is going up. I know as an emerge physician, I don't know every condition. A patient knows it better than I know. Shock, again, revelation. But sometimes you do have to look up these rare diseases. When you look up and you work in a tertiary, quaternary level center, it is challenging to be an expert on everything all the time. So I think it's that acceptance that we do leverage technology to help inform us, but we do have the layer and lens and expertise to help distill a bit more. And I think that's going to be where our roles are going to be in the future, because at the end of the day, patients generally still like to talk to a human. And we see that with virtual care a little bit, where people do like it, but they, at the end of the day, still want to see someone and be physically examined and have the stethoscope listening, their belly examined. And I think in the same way, they want to talk to somebody about the results. But I do think we have to be okay that they may know things ahead of time coming in, as opposed to surprise, right?
So how do we train our future doctors then, Amrit? If they're using AI, our role is going to change. How much is AI being implemented in the medical curricula, in the undergraduate curricula?
So definitely a lot more. And I think we are all still trying to find the best ways to be proactive with implementing, and maybe at this point it's not even proactive anymore. It's, I guess, already reactive. But I think Frank hit the nail on the head there that no one will know everything. There's core foundational knowledge you need, and we really need to focus on, and we are focusing on trying to train learners on how to critically appraise, how to find information, and how to understand what is relevant, and how to kind of sift through all the noise out there. There's a certain amount of stuff that you do need to know without having to look it up. Some things are core and you need to have that ready and you need to know that inside out. But there are some things where, yeah, maybe it's not the best use of time to have you memorize that for an exam, forget it 10 minutes later, and then constantly just re-examine you on something, as opposed to training you to actually synthesize knowledge, know where to look. And, even when it comes to stuff like these AI chatbots, we are integrating into the curriculum, having students critically appraise the content from them. I almost think of it kind of like when we were in high school, or I think it was high school back whenever like Wikipedia, I think for me it was kind of high school when it first sort of came out. And the initial thing was always like, hey, don't use this. You can never use Wikipedia.
Can't
Not
cite
reliable.
it.
Yeah.
Well, yeah.
It's not reliable.
Exactly.
Yeah.
And then we kind of evolved a bit, right? We're like, okay, it shouldn't be your primary resource, but as a good starting point to help you, know what to look up and then find some literature, real, actual peer-reviewed literature to support it. And I kind of think we're maybe going to go in a lot of the same direction with some of the foundational stuff from these chatbots.
So what are the tools that are being used now, that are being used regularly now and have got the most sort of momentum for a physician in practice, not for a hospital system, but for a physician in practice? What are people using?
Yeah. So I think you're going to always default to the open market ones. Like you're going to have your Geminis and your ChatGPTs, at least, again, not maybe looking things up, writing papers, like this is the other element of medical education. And I know we could talk about AI for hours, but, people will utilize it for drafting letters or reports or projects and things. So I would say they're using ones like that for a lot of that. They may be using it for patient-related stuff, but they shouldn't. That's one of the key things, is that when you have personal health information or patient specific or privacy-ish, you shouldn't be absolutely using the open ones the way that they are. I would say a lot of physicians, especially in the community, they're using these AI scribes that are vetted and procured by, provincial Ontario MD. And they're using them. Now, people are finding good successes and sometimes not successes.
So maybe, can you just, for people that may be not non-physicians that are
Yep.
listening to this, can you just describe what an AI scribe is?
An AI scribe is a tool that essentially is almost like an ambient listening system. So the same way you might just kind of put a recorder down, it listens to your entire conversation with you and the clinician. And then at the very end of it, will generate a note. It will take out kind of the banter. So it would probably take out this entire podcast, for example, but it would talk about the relevant stuff. So if they asked, where your pain was, how long it's been going on, your physical symptoms, your past medical history, and they talk about a plan, it would synthesize it in a way that is optically really nice for a note and makes it very clear. And the physician doesn't have to do that after. That's probably a good high-level summary.
And the other benefit for that, certainly there are administrative efficiencies with Scribe. So it'll generate consult notes, it'll generate prescriptions, it'll generate requisitions for lab work that you've talked about. But probably from a patient's perspective, one of the biggest benefits is that your physician is actually looking at you.
Yes.
Right. So that rather than having to, we've all experienced this and we've all done this, that, you're at the computer while you're talking to the patient rather than just putting the computer aside and talking and looking and listening at the patient. I think from a patient perspective, that's a huge win.
Absolutely.
Yeah, I would say most of us, like, imagine this was our encounter, and after this, I had to go spend 40 minutes typing up this entire encounter from memory and going in and there is a genuine burden, and so there is a perception that when we're rushing as clinicians, it's because we also know we have to do the other, paperwork aspect of it. So I'd say in this day and age where you're leveraging that, obviously to varying degrees of success in different parts of the province and hospitals, but that would be the most common. And then there's ones that you chatted about earlier about clinical decision making. making. Like open evidence is one for anybody listening that is an accessible, almost like a ChatGPT for clinicians, looking up dosages, medications, providing differentials, and it is sourced and procured with like the New England Journal of Medicine, which is one of the highest ranked ones that we have in medicine. So those are the ones I would say today and age that most clinicians are using.
Okay.
And I think one thing for clinicians who are just to take a step back, when we talk about AI, we're kind of talking about AI, large language models and chatbots for the most part here.
Yeah.
Certainly, we may be interacting with AI in terms of machine learning algorithms and things like that on a systems level. But I think for clinicians who are maybe new to this and who are starting to find different tools pop up, one of the things that's always helpful to know if you can find it is what model is that using? So what is the brain of the tool you're using? Because, most people can name, ChatGPT, Gemini, some of these other ones as well. There's a ton of these tools out there that are what we call wrappers. So that's wrappers with a W,
Yeah.
where it's somebody's taken
Thank you.
ChatGPT or Gemini
Yeah.
and then packaged it in a different way. So they've kind of pre-programmed the prompt to be, you are a standardized patient. So they might create a ChatGPT for practice OSCE cases or something like that, which is great. It's helpful. Just knowing that it may actually functionally be the same thing as ChatGPT.
Right.
So especially before people are starting to spend money on prescriptions, it's helpful to know, is this actually a specific model that's been trained on something, on a specific content, or is this just one of the standard ones that's been sort of wrapped up in this way as well?
I think that's quite common in the industry for anything.
Absolutely. That's when we keep talking about
any
the
of those
AI
tools.
bubble, right?
Right,
Yes,
right.
exactly.
Yeah, a lot of those scribes that I talked about earlier are actually very much that, right? Are just wrapper based ones because, and again, there's an art to actually using an AI bot too. The way you prompt it, how you type it in, how you teach it, it is actually does affect how you organically would kind of interact with it and the information it provides. There's so much you can get into, which I know is beyond the scope of today, but a lot of these have biases, and you have to think about how is it trained? Is it equitable? Does it actually represent the populations who made it? And what's the privacy and risk? Like there's so many layers to each one of those that we always have to be a bit cautious, but I think optimistically cautious kind of moving forward.
Perfect segue, because I wanted to get into what are the concerns with AI. Like there are some people that are concerned about it, and there are a lot of different sort of areas that are of concern. You mentioned privacy, for example.
Mhm.
What are the privacy concerns with the use of AI?
I think especially in again, at the year 2026, we talk a lot about data sovereignty. So, where does your information land? A lot of electronic health records are American-based companies. And so it's actually come up a lot in the last year due to, global events. Where is your personal health information? Where's mine? Is it actually housed in a server in the US or is it in Canada? So that's one question.
What is it being used for?
Correct. And so, and there are a lot of, even if it's housed here in Canada, can someone leverage it? Because there are, acts in the US where they could potentially take it, right? And so I think that is an extreme example, but people are just worried who is actually using this data. So the reason why I said earlier, you should not type personal health information into it for clinical care. One might go, what's the harm? Well, the harm is that information now goes into the organic ether that is the AI learning, and that lives there forever, right? It learns. And so who knows who just learned that? Who knows they can pull out that information? So I think privacy just alludes to who can access it. And let's be candid. In this year, it's very challenging to have completely de-identified person, like to lockbox your data in such a way. We accept that when we log into Google and have a Gmail, there's a level there that
Implied.
yeah, there's like a little bit of implied. So how do we find that bridge for AI use so people trust it? Because once you lose the trust with AI in clinical care, it is going to be very challenging to go back. So I think that's why we're got to be very careful because we want patients to trust it. We need to trust it. As soon as you have a landmark case where something went awry or a patient's data came out and utilized in a negative way, we're going to be 4 steps behind. So I think when people get really frustrated that we're not moving quick enough, there is a little bit of logic to that because you only get one shot sometimes with the trust.
And especially even in the creation of some of the algorithms that are being used, right? So where is the funding coming from? What is the access? Does an insurance company or a drug company have funding or access to some of these algorithms? So are we going to create tools where predicting whether somebody might need a certain drug or might need, warrant a certain diagnosis? And is there any say from people with vested interest in that as well?
The drug company is funding the algorithm in some
Exactly,
capacity. Then, right.
And it's almost like as a patient, there's almost a level of acceptance. Like if I was to say, can I use your data to, allow Roche to like suddenly make a whole drug, and they'd be like, no, I don't want that. But if I was to say, hey, in this hospital system, we want to train AI bot to help triage you a little bit more efficiently and book your appointments at a time. Yeah. Okay. Maybe that's, so there's layers within that AI gradients.
And I think when we think about safety and concerns, I think one of the things is, especially with chatbots, a fundamental misunderstanding of what they're doing.
Okay. So can you just define what a chatbot is?
So when we talk about generative AI, so something that kind of mimics human intelligence, that's able to create new content. And when I talk about a chatbot, I'm talking about those large language models, or those tools you interact with where they are talking back to you, whether that's ChatGPT, Gemini, or the annoying little Rogers Bell chatbot.
Right.
But I've had some
I want to talk to a human.
But I think, if you've ever used ChatGPT or Gemini, sometimes when you type something in, you get the little box that says thinking. And I hate that.
Yeah.
Because it's not thinking. Thinking to me implies critically appraising, reasoning. It is pattern recognition. And let me say, I use these for a lot of things, and I think they have a place, but it's pattern recognition. You put some words in, and it's trying to find the words that would best fit.
Right.
And I think the best analogy I can think of is, especially, bring it back to medicine. I don't know if you guys ever watched House back in the day.
I loved
House, right?
Yeah,
I watched it.
So it would be great if you had Dr. House making your diagnosis, but you probably don't want Hugh Laurie making your diagnosis.
Right.
They can both sound great. They can both put the words there. Hugh Laurie is a very talented actor who knows the right words to say in the right situation. I probably don't want that guy making the diagnosis. And I feel like that's how these chatbots work. They're Hugh Laurie, they're not House.
Yeah, but I'm okay with Dr. House with Hugh Laurie's voice.
Yes,
that would be okay.
There you go.
Exactly.
There you go.
Yeah.
What about bias? You hear a lot about bias, and why is there bias in a computer? How can a computer have bias?
A computer and AI is as good as the data that trained it.
Okay.
So I think maybe easiest example I can think about is if you've ever Googled a rash, eczema, chickenpox, 99% of those images are going to be on white skin.
Right.
So if we say that, hey, we gave this chatbot 100 million images of eczema, it can diagnose eczema now. Well, there's a good chance that it hasn't really seen a lot of eczema on black or brown skin, because there's not as much of that in the public domain. So that chatbot may not actually work for everybody.
Yeah. And same goes with age too. So there's often, for example, there's one that's a predictive model to allow us to see who are the sickest patients, but it's only been trained on ages 18 to 65. So do you allow that to be deployed in your hospital, knowing that it may not represent the extreme examples and it may have a bias, right? Or do you just say no because it's only been here? It's had a few of the extremes. And so it's just a good example that we have to, when we're judiciously picking these tools, it's going to be challenging to find something that works for everything all the time. On the same note, if you don't recognize the bias it may have, when you implement it, it may actually skew and underrepresent certain areas. So if in a bubble, you only train it on that exact example, you're going to misrepresent things. And so a lot of these larger ones have kind of done a better job, I would say in quotes, but you still don't know. And so in a hospital system, as we start to look at potential solutions and more specific stuff, we really have to make sure that it actually had a diverse population, and that represents both from skin color, gender, equity, lower, higher socioeconomic status, rural, urban. Like, we have to consider all of these things when we're selecting it.
And I think because these tools can sound so smart, people think that it's not a big deal. One of the best examples I always remember was asking ChatGPT to draw a picture of a wine glass filled to the brim, and it couldn't do it because it's such a simple task. Any of us could draw a wine glass filled to the brim. But because when you take a picture of a full glass of wine, you always have a little bit of space there.
Yeah.
Maybe not after a long shift on a Friday night.
Oh,
but
no,
as you can imagine, what's available, this tool that seems like it can do everything just could not make that image, no matter how many times you queried it and asked it. And the one way that somebody actually got it to do that was to ask it to describe what a wine glass filled to the brim would look like, and then use that. And then that was like the closest.
Okay, so we're going to have to move on, and just in the interest of time, especially if you two start talking about chips and dip and other sorts of things.
Oh yeah, that's the after behind the scenes podcast part. Yeah.
I was told there would be chips and dip here.
Yeah, those are coming. You didn't see them in the green room?
There's a green
I was
room.
told there would be a green room.
Anyway, so where are we going with this thing? Let's talk about the future. This is moving at light speed. What does the future look like with respect to the use of AI in medicine?
I think the biggest thing that we always have to wrap our heads around is kind of who's driving the ship. What is the governance around AI? Because everybody wants to use it, but we just talked about the risks with that. But there's also a risk of not doing something too. So if we know the technology is there and we don't do anything, that is equal risk. And so we have to kind of make this decision, and you have to do it with all those lenses. So you need clinical at the table, you need leadership at the table, you need politics and, you need those sort of leaders at the table, but you need ethics and equity, and you need all those people weighing in, helping, kind of almost like a council, if you will. And so where we're heading, I think, is going to be driven by a lot of those voices, and who those voices are going to be the ones that dictate, how aggressive we be. I think as Canadians, we are pretty risk adverse as a nation. And I would say certainly in healthcare, we're so concerned about the risk, and hospitals are concerned about the risk. But as we move forward over the next, if I was to say 5 years, what you're going to see is AI absolutely used more. You're going to see it silently working in the background. Something we didn't get into specifics, but there's something called agentic AI, which is basically the way, for those listening that know about like Skynet, making decisions without human interaction. That's going to be there in the background, kind of guiding and alerting, for sicker patients, for example. There's going to be AI that you're going to see when you see your clinician, who's going to use those AI scribes we talked about. And in the background may even be influenced from a perception of like drug uses and differentials. So it's going to be in all aspects. But for the clinicians listening, you have to also recognize it goes the other way, that we have to be ready, that patients are going to be armed and appropriately informed with AI too. That's where I see it in the next 5 years.
Absolutely. And I think from an on-the-ground level, as a healthcare provider, as a physician, when you are interacting with a trainee, when you're interacting with a patient, assume that they have access to and will be using this in some way, shape, or form. So have that discussion, make it an open discussion, talk about the pitfalls, talk about the potential benefits, and encourage an open dialogue. So when you are doing teaching, I'd say bring it to the classroom. If you are doing a lecture about, approach to chest pain, bring up ChatGPT, throw in one of the cases, and instead of just having the students answer what they think, is have them critically appraise ChatGPT's answer, Gemini's answer. Teach them how to figure out what's right, what's wrong. With your patients, bring it up. Say, hey, you may be using these tools. You should know that they may overgeneralize and they rely on pattern recognition. You may find them helpful for some things, and if you see anything that conflicts, talk to me, talk to your family doctor.
Yep, great. That's great insight. It's interesting to talk about the governance of it, because it kind of feels like we're in the Wild West of AI right now. There are no guardrails. People just don't know what they can use, how they should use it, other than their own sense of sort of professionalism and sort of knowing your own limitations. At the conference, we're going to be having a panel that's talking about governance and regulation. We'll have a representative from the CPSO there and someone from the CMPA there. Where do you think that should head, the whole issue of the governance of this stuff?
Oh, yeah, nice light topic. I think in the way, if you look at us as a country, we have a federal portfolio dictated just for artificial intelligence. So already you have a signal that this itself is not a fad; it's important. And so from there, you're going to see a trickle-down effect of probably what are going to be guidelines and policies that are going to be replicated at a provincial level. And I suspect over the next few years, you're going to see very quickly the provinces start to mobilize to provide guidance to the hospitals. Because right now, the Wild West is a great example, early teenage years almost, of like, yeah, we're finding our feet, we're finding use, but it's still kind of an awkward phase because hospitals are kind of having to stand up their own strategy. If you were compared to some of those Toronto hospitals, to our northern hospitals, to where we are, we have vast, maturity when it comes to AI, and that can be either directed because of the people at the helm or where the priorities were. So I think what you're going to quickly see is hopefully more of a coalescing around more a uniform kind of prescription that will help move the hospitals forward. Because when you get bogged down in policies and governance, that's probably where we need to be right now. But if you're still doing that in a few years, you're behind the 8 ball.
And I think one thing I'd say is we need to move faster than we did with previous technological innovations. And I use social media as the obvious answer, or example rather. it took so long for governments to start taking this and policymakers to start taking this seriously. This isn't just a fun tool. This has real world implications. And I'm glad to see that they seem to be moving a bit faster with this. So I think, we need to make sure that there are strict standards that the tech companies need to adhere to in terms of safety and safety nets. And I think from a government perspective, we need policymakers to make sure that the most vulnerable populations are protected, because those are the people who are going to be disproportionately relying on these tools for important decisions.
So we call ourselves the Hat Rack because we want to give our listeners something to hang their hat on.
But I'm not wearing a hat.
Okay. You've heard that term before, haven't you?
Yes, I have. Yeah.
All right. So I'm just going to give each of you the opportunity to give our listeners one or two things that you think that they can hang their hat on, things that are as irrefutable that we're going to be heading with AI and how they should be using it.
I think that you can assume every part of your clinical care will have a touch point with AI, even as of today, but certainly within the next year. That is, for me, a definitive answer. And we can also assume most non-clinical people will be leveraging AI in some capacity to look up stuff.
Okay.
I think you can hang your hat on both of those.
Buckle up, it's coming.
It's here.
It's here.
It's here. It's here now, and it's going to be more embedded. So those are my two.
It's here, and it's been here for a while. If you think you are someone who is not using AI, you are using AI, because the amount of content that has now been largely generated with or enhanced by AI is overwhelming. Virtually every time you have used Google or any digital resource, there has been a lot of AI in that. So we are all using this. And I think we need to make sure that we're having those open dialogues.
That's great. Look, I want to thank you both for coming in and having a conversation. This has been really great. It also is a really great preamble to our conference, which is coming up in just a few months. And so we hope some of our listeners will check that out and maybe want to attend.
Well, it's great. Thanks for having us, Bill.
Thanks so much.
Well, I found that super interesting, as usual, as I do with all my guests. But AI is a train that is moving so fast. We need to get on board that train. Those of us who are physicians in practice need to understand, as Dr. Kripalani said, that we are using it whether we know it or not. So we might as well learn how to use it properly, learn how to use it to our advantage, learn how to use it to the advantage of the patients that we're seeing. Because a lot of these tools ultimately will help patients in their patient care.
You've been listening to The Hat Rack, hosted by Dr. Bill McCauley from Continuing Professional Development at Schulich School of Medicine and Dentistry, Western University in London, Ontario, Canada. Technical assistance for The Hat Rack is provided by Patrick Barfoot, Technology Support Specialist at Schulich. Original music was composed by Cameron Bereznik. Please contact us with any questions, comments, or suggestions for future topics or guests. We can be contacted by email at thehatrack@uwo.ca. Additional episode information can be found online at schulich.uwo.ca/CPD. For The Hat Rack, I'm Kimberly Bukala, Educational Developer at Schulich School of Medicine and Dentistry, Western University, leaving you with something to hang your hat on.